Hello, dear colleagues. My name is Falk Ochsendorf. I'm professor at the University Hospital Frankfurt at the Department of Dermatology. And the topic of my talk today is tolerability of topical treatments in acne, especially to improve the topical tolerability. Now, to jump into the problem, you have this girl, she's 16-year-old, and says, well, I applied what you prescribed me, and now I look like this. What happened? We'll see later in the talk what happened. And the learning objectives, after you work through the CME, you should be able to describe the fine balance between tolerance, effectivity, and adherence, to discuss the effectivity and the tolerability of topical compounds, the retinoids, benzoyl peroxide, antimicrobials, acylic acid, and the role of fixed combinations, and to discuss possibilities to increase the tolerability of these compounds, especially the role of the concentration and contact time, the role of the foundation, and the use and the role of adjunctive cosmetics. Well, is this a relevant topic? Should you follow this talk for 60 minutes or not? Well, why do you think so? Think some seconds about this question. And the outline of my talk will be, is this a relevant topic? We're here already, and then we go through the other points. Well, when you think of acne therapy, there's a fine balance between tolerance, adherence, and efficacy of the treatment. And if we look like it here, like a horizontal bar, and it's on one place here, and it has to be in the balance. And if you have a bad tolerance, the patient will not adhere, and then it won't be effective, and you have no therapeutic success. If the patient doesn't adhere, the efficacy won't be good, and if the efficacy is not good, he does not adhere. And therefore, the tolerance is really a cornerstone of a good therapeutic success. And this is reflected by the fact that some years ago, a group of experts, they made a big study to define core outcome sets for acne. That means which is really relevant for the patient and should be included as outcome sets for future acne studies. And what came out was satisfaction with appearance, the extent of dark marks and scars, long-term acne control, signs and symptoms of the disease, satisfaction with treatment, the quality of life, and the adverse events. So it's a core outcome set, the tolerance. And it's especially relevant as acne is a chronic disease. And if you think of this statement, you may think, well, acne is a chronic disease. Well, if you compare it to atopic dermatitis, it lasts more than 3 months, 2 years. It has a genetic background. The onset is with 10 years at the first year of life. In many cases, it's self-limiting. After several years, you have to counsel the patient, you have to take medication continuously or in intervals, and then again for a longer period of time. It has social impact, psychological, can lead to scarring, and has psychological sequelae. So it's a chronic disease. And therefore, especially in a chronic disease, the topic is relevant because if you don't use an effective therapy due to side effects, you won't succeed. And therefore, we have to deal with this aspect. We have to do everything that we have a good tolerance of our topical therapies. Now we come to the next point. We look at the guidelines and look what do they recommend. And then you can look here in the columns which type of acne you have, and here which compounds are highly recommended, how is the evidence for these recommendations, and you can choose from this list. And now we have to look for these compounds which are recommended. How are their side effects? And here are these compounds, the retinoids and the other compounds. And what do you think? Which compound is most effective? And which of these compounds lead to earlier termination of therapy than you want it to be terminated due to side effects? Think some seconds about these two questions. Well, there was a study. It's not in print. It's just ahead of print. Big study where the authors screened many texts with many participants with mild to moderate acne, and primary outcome was self-reported improvement and the trial withdrawal. And they investigated trials till mid of 2020. And what came out was that BPO works better than the vehicle. The fixed combination BPO adapalene works better than the vehicle, and the fixed combination BPO clindamycin works better than the vehicle. But be aware, the vehicle improves in every third patient. Already the vehicle improves the acne. And the withdrawal rate was highest with BPO adapalene or BPO clindamycin than with the monotherapies BPO and adapalene. And this is shown here in this chart. But you see the withdrawal rate was rather low. Nevertheless, most patients tolerated the treatment, but the chance was highest with adapalene BPO, then clindamycin BPO, and the least with the antibiotics. And that is one reason for me why antibiotics are, that was the improvement. That's the work best. That's the improvement. It shows the same with the prior termination and the adverse events. You also have with the adapalene BPO, you have the highest rates. And then comes BPO and clindamycin BPO fixed combinations, and then the rest. And you see the side effects are very few with the clindamycin or the combination of clindamycin. But in the guideline committee, we all struggle a lot to prevent topical use of antibiotics, especially monotherapies. But many physicians, especially general physicians, they like the topical antibiotics because they have so few side effects. You don't have to explain much. You don't have to care about tolerability. But therefore, the effective therapies, they have irritation potential. That's what comes out. Now, coming again to the effectivity, what do you think, which compound works best for comedones of the ones I already named? Okay, and you see the oral isotretinoin works best, and then the topical retinoids, and then interestingly, this anti-androgen combination therapy for women, then BPO, and then the rest. Therefore, the retinoids are worth a consideration because the retinoids work best against comedos, which start the acne. And which compound is least irritating? We can make it short because I already said it. And here, if you look and compare these lists, and you see the topical antibiotics, they have just 20% with maximum, and the acylic acid also has not much rates. The BPO in these studies comparable, and the highest rate here is, as I said before, BPO adapalene, and the retinoids even more. And here you have to be aware that it's only 40%. You see, here's 80 everywhere. So it looks the same, but it's much less. The clindamycin BPO has a good tolerability. And this is a table which shows this in one view, that the tretinoin has a lot of potential to irritate the adapalene much better. I come to this very detail in a minute. Benzoyl peroxide is in between, and here the topical antibiotics, they show good tolerability, but they have other problems. Now, coming to the retinoids, also they are very irritating. They are very effective. And therefore, what do you think? Is there a difference between the different retinoids concerning effectivity and the potential to irritate? Or can you take any of those retinoids? And you see, this is the timeline. Retinoids are available since 1971. And then they were modified by other foundations, cream, gel, other concentrations. Then new retinoids came into the market like adapalene or tazarotene. Then they got the microsphere, micronized preparations, a foam preparation, And then the newest one is the trifarotene cream. And so there's an evolution with time. And there was a recent systematic review or overview about the topical retinoids. And I don't want to go into detail, but I just want to show you the tretinoin gel, interestingly, was less irritating than the tretinoin cream. I don't know why, but at least it's in this paper. And the tazarotene gel was leading to erythema in almost every patient. And in many reports, there were not reported. So you cannot compare it. But in other papers, if you compare it, you can see that the least irritating of the compound, it depends on the percentage of the tretinoin. Then a low percentage is as effective as the adapalene, but higher concentrations are working better, but have more side effects. And if you have a special foundation with these microspheres, then still adapalene is least irritating. And this also holds true for the isotretinoin, which is less irritating than the tretinoin, is as effective as the adapalene, but has more irritating, and the tazarotene has more side effects than the adapalene. And if you put it in another view like this, and you can see the adapalene is the least irritating retinoid, although in some patients it still can lead to erythema, scaling, and dry skin. And if you compare these side effects, the tolerability with other compounds, you can see the potential is higher than with acylic acid or BPO, and especially the topical antibiotics. The newest retinoid is the trifarotene, and they made a special device that how to take right amount, and one actuation is sufficient to treat the face, and if you treat the trunk, you have to take another actuation. And also here you find mild erythema, mild scaling, and dryness during the first week and during the first 4 weeks. I come to this later. And therefore, as I just explained, if you have higher concentrations of retinoid in your topical, there's a higher potential for irritation. And the irritation, dryness, and erythema comes up during the first weeks of treatment. And it's irrespective which retinoid you take. So you can tell the patient in advance that he will experience some irritation. And if you say, you will experience irritation, that's bad. But if you explain that the irritation is a sign of the effectivity of the treatment, then it's positively correlated. This means if you notice a burning, stinging feeling, then you notice that the drug starts to work. Then the patient expects this and is not astonished, and it's even a positive sign. And if you know the patient is a patient with atopic dermatitis, then perhaps one could start every second day, but I come to this later. And 4 out of 10 patients will experience some side effects, and every second patient discontinues it. And therefore, you have to pay attention to that. It's essential in the beginning to address this when you talk with your patients. And I here refer to my talk on improving adherence. Perhaps you may be interested to listen to that as well. So if you prescribe retinoids, you should know which concentration you use, which vehicle you use, how is the sensitivity of the patients, and then you choose the specific retinoid according to these factors. And then you should, depending on these factors, start perhaps with a lower frequency, with a short exposure. You have to explain the mode of application. It means the whole face. You perhaps be careful with the sun and combine it with cosmetics, as I explained in the last part of my talk. Coming to BPO. Benzoyl peroxide is better than no treatment. This is also a recent systematic review. It's in this review was shown to be as effective as adapalene and clindamycin, and the withdrawal compared to no treatment or vehicle was higher. And again, there were topical side effects like burning, erythema, and pruritus. But the evidence was low. Apparently, there's not much difference to the rest of these compounds, but the study did not allow a better conclusion than that. The side effects are mild to moderate at the application site. And as I said, it's uncertain whether it's increased compared to these compounds, perhaps a little, just about to cross the one with clindamycin appears to be better tolerated. And you could decrease these side effects by combining BPO with moisturizing substances or special foundations, and by combining these different aspects. However, we know this patient already. She came with a red face at the start of this talk. And what we did was an open application test. At her arm, she applied the BPO, which she received for her acne. And you see an acute contact dermatitis. And you have to know about 1%, depending on the studies, between 0.2 till 6% may experience a contact allergy to benzoyl peroxide. So if a patient comes with red face, be aware it may be a real allergy. Coming to azelaic acid, it's less effective than BPO. In a recent systematic review, it appears to be as effective as tretinoin and clindamycin, and we don't know whether it's as good as adapalene. And compared to other compounds, withdrawal rate was about the same with all these compounds used. When you look at, you cannot read it, but it just shows you it's compared to the vehicle, there's also always not much of a difference. So the side effects with azelaic acid are very, very low. Coming to the salicylic acid, there are not much studies with salicylic acid in acne. In many cases, incorporated in cosmeticals, as I just show you. I will show you in a minute. And physician global assessment of acne, there was no difference to tretinoin, and also no difference to tretinoin BPO. Perhaps it's not, we underuse the salicylic acid, because they used it in a cosmetic, and you see just with this salicylic acid based preparation, you could decrease the pustules and the comedos. And this is the composition, and they used one preparation in the morning, one in the evening, and the cleanser twice daily. So this has a potential to be used with a good tolerability. Now I'm coming to dapsone. This compound is not available in Germany, but from the publications, you see it's a little more effective than the vehicle and has about the same amount of side effects concerning dryness and very rare cases of pruritus. The newest compound is clascoterone cream. It's not available in Europe by now, but it's licensed by the FDA in the USA and is an anti-androgen. That is interesting because it's a different approach to influence the acne pathophysiology. And as you can see here, the testosterone binds to the androgen receptor. And because the clascoterone binds to this receptor, the effect of the testosterone is prevented. And it has some effect on the acne, and that means reduction of the IGA score about 1 or 2 within 12 weeks. And in the treatment arm, 20% reached this, and the vehicle arm only 6%. And the side effect profile was some erythema in the first few weeks, and then about every 5th patient over 9-month therapy. 1 in 10 had scaling and dryness, and 1 in 20 some pruritus. So a good tolerability. Another new compound, also not available in Europe, is minocycline foam, better than the vehicle, with a good safety profile, good tolerability. However, I have my reservations against topical antibiotics as a monotherapy, as I just mentioned before. So this should be combined with BPO, and then we have the BPO irritation potential as well. Okay, now the question is, we have these monotherapies. Now what's happening when we combine the drugs? We can assume that the efficacy will improve, but perhaps the tolerability will get worse. And therefore, we have to think what's happening when we combine the compounds. One, we already had contact with that in the beginning. Very effective BPO adapalene shows that the fixed combination is more effective than the monotherapy with either adapalene or BPO, and both are better than the vehicle after 12 weeks. And if you look at the side effects, you see that in the beginning, in the first 4 weeks, the side effects are increased over the BPO and the vehicle, and a little more than the adapalene. And as I said before, if you educate your patient and say this before, it should be no problem. If you compare different studies as done here, every form is a different study. It shows the same, that you have in the first 4 weeks, you have erythema, scaling, dryness, stinging, burning. And if the patient continues to apply the compound, it goes down and disappears. Coming to the fixed combination, clindamycin BPO, and you can see the same after 11 weeks, significantly better global improvement than the monotherapy with clindamycin or BPO or the vehicle. And also the side effects, rather few. And you see here the monotherapy, clindamycin, BPO, and the vehicle. And with combination therapy, you're about the same percentage of dryness, burning, and stinging. So no increase of side effects, even better, about the same tolerance. And if you compare these two compounds, which are also got the highest recommendation in the European S3 guidelines, you see why. Because they have a strong efficacy on inflammatory, non-inflammatory, and total lesion count with no difference. But the tolerability of the BPO adapalene fixed combination was less than the BPO clindamycin. They had the people with BPO clindamycin had less stinging, redness, burning, and therefore it's got a better tolerability profile. Now we heard that acylic acid is the one of the least irritating, best tolerated compound. And if you compare it to this lower dosage of fixed combination BPO and clindamycin, you can see better improvement with this fixed combination, while the tolerability was also better than the acylic acid. You see, this is without, so that means the higher the scale, the less people have dryness or peeling and erythema. And you see no difference, or a little better is the fixed combination. So it's a good thing. And also the fixed combination clindamycin tretinoin concerning efficacy shows the same, better than the monotherapies with clindamycin tretinoin or the vehicle. And here you see no difference with the vehicle or the respective monotherapy piece of the fixed combination product. So this is a very well tolerated compound. Now you see we have several good or well tolerated compounds. However, some of them, like the retinoids and the BPO, still have some irritation potential. And the question is, what can be done to improve the tolerability, and therefore that the patient apply the therapy and the effect that it is effective. And now I have a question for you. What would you recommend to increase the tolerability? What do you advise? How do you advise your patients? Well, you could either reduce the concentrations, we heard this with respect to the retinoids, or we can reduce the frequency of the application. That means every other day, for example, or we could reduce the contact time. And we go into the detail now. And for the last thing, invented the short contact therapy. That means they used it only 30 minutes once daily, whether the standard application. And after 12 weeks, you had, with only 30 minutes on the skin, the same efficacy, but only 17% got irritation, while here it was about 20%, 50 up to 50%. And here you had less discontinuation of the treatment due to irritation. Only 1 of 20 patients stopped therapy due to irritation. And this is another example where they combined tretinoin, clindamycin, and glycolic acid in a certain gel. And here again, you see when you use special gels, then you could increase tolerability. And you had, with the standard, you had a dropout rate about 20 to 25%, and only 8% dropouts with a short contact therapy. And the same held true if you alternate what I said before. If you use it every second day, with tazarotene, you get the same tolerability and efficacy as if you use adapalene every day. And here's an example of the good effect of tazarotene. If you use benzoyl peroxide, you have to be aware that even lower concentrations of BPO are effective. So 5% are about as effective as BPO 5%. As you can see here, concerning the reduction of papules and the reduction of pustules, even as effective as a BPO 10% concentration. So lower concentrations suffice. And also here, they tried to decrease the contact time by using foaming cloths, BPO containing cleansers, or BPO washes. And I just show you one chart of this publication. And what you can see is that this cleanser the convenience attributes compared to this cloth were less good than with this foaming cloth. So if you use these for a short period of time, apparently the patients like it. Then we mentioned this quite often, the vehicle effect. This is something which is investigated by the pharmaceutical companies because they want to find products which are used. And it's very difficult to understand everything of this. But you have to know or be aware that choosing a right foundation really is relevant to increase tolerability and to decrease side effects. And sometimes just changing the vehicle may be the thing which should be done. And it's the topical drug products, they use many different compounds who try to encapsulate the drugs that they are better transported into the skin. And these are names which you may read in publications: liposomes, niosomes, ethosomes, transferosomes, nanoparticles, and so on. And there are many studies demonstrating that this is really something useful. And here you see, for example, this microsponge delivery system where you have much less erythema and paling when you use these compounds than if you use the application without them. Another thing was they micronized the tretinoin, and therefore the dryness and erythema went down. The same holds true for tessarotene, where the incorporation here in this honeycomb mesh decreased the application site pain and the dryness. For BPO, they investigated several microsponge systems with different ways, and this significantly reduced the irritancy and was superior in clinical endpoints and had only a mild irritation potential. Or they used nanoparticles. Again, drastic reduction of irritating effects, superior tolerability, no signs of dermal irritation. So if you are confronted with a new foundation of these compounds, you should try to use these advantages of the formulations. And this is, again, something, a scanning electron microscope, and you see here, this is Prevoxyl gel, 4%. How is it released? And if you have other prototypes of the silica gel preparations, they work more or less in the way that the release is in a way that the irritation potential goes down. And this can be shown here with these different preparations, that the improvement is better and the irritation potential is less. You see here a number % of patients who have side effects, and you see with the standard preparation, many patients have very slight or slight side effects, and here only few people have side effects. Okay, this is just nice to know because you cannot invent a new foundation or new vehicle, but you have to rely on pharmaceutical companies. But you can use products which increase the tolerability, and these are adjunctive cosmetics, and you should combine them. And interestingly, if you have a standard text, when I was an assistant, when I learned dermatology, it was the standard acne and rosacea from Plevik and Klickman. And when you look in the index, there are 11 pages index. And when you look at cosmetics, you find acne cosmetica and a table and camouflage. That's it. No moisturizers, cleansers, sunscreens are not mentioned at all. And when you look into the text, you see, well, there were the detection of cosmetic acne. You use a rabbit ear, and you have some human tests for that. And you have names for it, acne venenata, cosmetic acne, pomade acne, that if patients use certain cosmetics, they get acne. And the reason for that were irritation and the application of comedogenic substances. And that you have to think of this. If the acne does not go away, it persists, although your therapy is adequate. And then you find many closed comedos, very many lesions. Distribution is in the center of the face, and it's often associated with perioral dermatitis. And these are compounds which may created depending on the concentration, interaction, and the individual reaction of the patient, which decides about whether a substance is comedogen. But today, this problem is very rare because the companies know that, tested before, and so it's rarely a problem, but you have to think of it. It evolves slowly over months, as I said before, when the therapy does not work as you think. We're already here. And now the question is, what do you think? Which kind of cosmetics are most relevant? Which cosmetics should I use, or which are most beneficial? What do you think? If you have this simple scheme, you have cleansers, you have hydrating and replenishing agents, and you have sun protection. Now we start with the cleansers. Normally they should remove dirt, oil on the skin, and if they are too aggressive, they may weaken the barrier function, leading to increased water loss. And if you scrub a lot, then the same happens, and therefore substances which have particulate matter or use soaps with strong detergents, they shouldn't be used in acne. And here's an old study, but it's quite interesting. If you use a Zyndet and you compare it to a normal soap, then these are the number of inflammatory lesions. Then after 12 weeks, just by using a cleanser with a Zyndet, then a soap is improving the acne. And these are typical compositions. And here the message is use a Zyndet. And here are also studies demonstrating that. For example, here with benzamycin or benzamycin adapalene combinations, one used a soap bar, the other a mild Zyndet bar. I don't get money from Dove, but it was used in this study. And after 4 weeks, there was an evaluation. What you can see is that the mild soap bar decreased the erythema, and the soap increased it, and increased the dryness, the burning, the stinging. Concerning the acne was improving when the people used the mild Zyndet bar, the whiteheads and the blackheads and the oiliness, and therefore a good cleanser, a Zyndet, can be recommended. And here another study where they draw the change in acne-related symptoms, the closed comedos and the papules, which also improved. And the patients also liked it. They said these cleansers did not dry skin, did not irritate, and they could better use a retinoid with this cleanser in 85% than without it. Therefore, cleansers, Zyndets for cleansing should be recommended. Coming to the next point, the moisturizers. The moisturizers can be differentiated into humectants, occlusive, and emollients. And common moisturizers ingredients are listed here. And the typical moisturizer humectant contains glycerin. This is relevant. And when you look at if you try to prove that the moisturizer works, you have these possibilities. And when they check that, they could find out that it's effective. And the moisturizer can be applied over the topical medication. So you can use the BPO and then the moisturizer. You can use it everywhere on the face. And if they're in the humid months, that means in summer when you live in a climate with big humidity, you shouldn't use it because it's too much hydrating. And if it's a low humidity condition, you could use it. But you can see here that if you use the moisturizer, the dryness goes down, and if you stop it, it comes back. And the comedos improve, and when you stop the moisturizer, they return. So this can also be recommended. And here is also a study showing that the skin felt better, smoother after the moisturizing cream. And here is another study showing demonstrating the effect of a moisturizer applied 10 minutes prior to adapalene BPO, and the patients also received a tutorial how to apply this. And what you can see, if you know the studies in the first four weeks, you had above 1. You remember, you have here no treatment. It's the same picture here. And if you use this moisturizer, it barely irritates, concerning erythema, dryness, scaling, and subjective burning. So this is a good idea to use a moisturizer. And it increases, again, they use the adapalene BPO fixed combination, and the patients who use this, they have the better potential to manage their skin irritation. They were more compliant, and therefore this is a good idea to combine this treatment with a moisturizer. If you use it too much, you can get this perioral dermatitis. Therefore, it shouldn't be used too much, as I said before. The next thing is humectants, and they contain glycerol. And the glycerol leads to an enhanced corneocyte envelope maturation, as you can see here, and therefore the skin feels smoother. And the last thing is there are occlusives, because they retard the water loss, and they contain mineral oil or petrolatum or dimethicone, and can also be used, but the studies were done with the compound I showed you. Coming to emollients, they contain a glycolsteroid, glycerylsteroid, lanolin, and they spread easily on the skin. They make a partial occlusion and also hydrate the skin. And when you look here, again, if you combine here your topical with a glycerol, then the dryness score goes down compared to control group. And this is a program which was published in a study years ago, where they tried to decrease the irritation potential of retinoids, and that's how they did that. They used a cleanser, a moisturizer, and then the control regimen used this. And what you can see again, that the flaking with this, they used an image analysis, improved when they combined it than if they just used the control regimen in the black. And it's in these compounds, in these cosmetics, there are many compounds incorporated. And if you read them, you should at least have some idea what effect they should have. These compounds here, they should have anti-inflammatory actions. These compounds are said to have sebum control. I referred to this publication. Some have antimicrobial activities. Some, like the salicylic acid, the retinol derivatives, they are keratolytic. And some have antioxidant properties like vitamin C and vitamin E, and have a mixture. And normally you don't have good studies. They placebo controlled in large numbers to really demonstrate the effects. But as I could show you, even the foundation of these humectants and the cleansers are able to improve the tolerability of anti-acne agents. And if you have more of these ingredients, they may have even a better effect. And if, depending on the individual patients, if they have a strong inflammatory activity, perhaps you choose compounds which include these compounds. If you have patients with many comedos, perhaps you choose compounds with which contain these ingredients. Lastly, as I mentioned it shortly, you should inform the patient that some irritation will take place, as I said it before. And if you take it if you discuss it with your patient, if you don't put it under the table, it's much easier than if the patient returns, has a red face, and say, "Oh yeah, I know it gets worse." Then you lose your credibility. It's helpful if the patient can read things at home. And one thing is very important: you should educate your patient about the correct use. And as I stated in the other talk on adherence, let the patient repeat how he should apply it. Then you know that he understood it correctly. How often, how should he apply it, and what should he do in case of problems? And I refer to this CME. So the take-home message of this talk is, you should consider tolerability as a key factor for a successful therapy. Otherwise, the patient won't use your medication. You should use the best tolerable products you have. If you have a product which works good, but the tolerability is not good, you can increase the tolerability by lowering the concentration or lowering the contact time. You can use less irritative foundations if they are available. And you should be aware that the combination with cosmetics or cosmeceuticals like cleansers and moisturizers can be recommended and can improve the tolerability substantially. And you should educate your patient on the correct use of both the anti-acne treatment as the adjunctive cosmetics. Thank you for attention.